Welcome to today's Rapid Fire Explainer covering breast pathology and clinical management. We've got a lot of ground to cover, so let's jump right in and test your knowledge.
Question 1. Which of the following physiologic changes in the breast is not associated with pregnancy? Is it A. Accumulation of lymphocytes, plasma cells, and eosinophils, B. Enlargement of breast alveoli, C. Release of colostrum, or D. Accumulation of secretory products in minor duct lumina?
If you went with C, you nailed it. During pregnancy, the breast is going through some intense proliferative and developmental maturation. It gets bigger thanks to all those hormones, lymphocytes gather up, and the minor ducts branch out. But the actual release of colostrum, that early milk, is strictly a postpartum event. So your crucial exam pearl here, always distinguish the gestational maturation that happens during pregnancy from the postpartum lactation that happens after delivery.
Question 2. Which of the following statements regarding axillary lymph node levels is incorrect? A. Level 1 nodes are lateral to the pectoralis minor. B. Level 2 nodes are deep to the pectoralis minor. C. Level 3 nodes are medial to the pectoralis minor. Or D. Level 4 nodes are the ipsilateral internal mammary lymph nodes. The incorrect statement is D. Axillary lymph node groups are strictly defined surgically by their physical relationship to the pectoralis minor muscle. Level 1 is lateral, Level 2 is straight up deep to it, and Level 3 is medial or superior. Those internal mammary lymph nodes, they're a totally separate nodal basin entirely. The major exam pearl you've got to lock in is that there is absolutely no such thing as a Level 4 in axillary node staging.
Question 3. Taking a look at gynecomastia. Which of the following is true? A. During senescence, it's usually unilateral. B. During puberty, it's usually bilateral. C. It's associated with breast cancer and Klinefelter syndrome patients. Or D. It's classified by a 3-grade system.
The true statement is C. On its own, gynecomastia doesn't generally predispose the male breast to cancer, but the hypoandrogenic state of Klinefelter syndrome, which is that XXY karyotype, comes with a significantly higher risk of male breast cancer. So the exam pearl is that gynecomastia alone doesn't raise cancer risk, but the underlying genetics of Klinefelters definitely do. Quick side note to correct those other options, senescent gynecomastia is usually bilateral, pubertal is usually unilateral, and it actually uses a 4-category grading system.
Question 4. Benign breast lesions with a higher risk for subsequent malignant transformation include all of the following except A. Intraductal papilloma, B. Atypical ductal hyperplasia, or ADH, C. Sclerosing adenosis, or D. Atypical lobular hyperplasia, ALH.
The exception we're looking for is C. Sclerosing adenosis is super common during the childbearing and premenopausal years. And yes, it is a proliferative lesion, but crucially, it has zero independent malignant potential. Now, multiple intraductal papillomas, ADH, and ALH, those all absolutely elevate a patient's lifetime risk for developing breast cancer. Your key pathology exam pearl? Proliferative lesions without atypia lack independent cancer risk.
Question 5. Which of the following protective lifestyle factors can successfully reduce the risk of developing breast cancer? A. Early menarche. B. Nulliparity. C. Late menopause. Or D. Longer lactation periods.
The protective factor here is D, longer lactation periods. The core driver of risk boils down to your lifetime exposure to uninterrupted estrogen cycles. So anything that maximizes your total lifetime menstrual cycles, like starting periods early, never having kids, or hitting menopause late, is going to bump up that risk. On the flip side, longer lactation periods and moderate exercise actually cut down the total number of ovulatory cycles. The exam pearl to remember is that breast cancer risk strongly correlates with lifetime uninterrupted estrogen cycle exposure.
Question 6. All of the following are true concerning breast lobular carcinoma in situ, or LCIS, except A. Develops only in the female breast. B. Cytoplasmic mucoid globules are a distinctive cellular feature. C. Frequency of LCIS cannot be reliably determined. Or D. The average age at diagnosis is 65 to 70 years.
The false statement is D. Cytoplasmic mucoid globules are totally a hallmark of LCIS, and it does indeed develop exclusively in female breasts. And since it doesn't really show symptoms, the true population frequency is pretty tough to pin down. But the age is where option D gets it wrong. The average age at diagnosis is actually around 45 years old. That's a full 15 to 25 years younger than the average age for invasive breast cancer. So your exam pearl,
LCIS is basically a risk marker that's typically found completely by accident in premenopausal women. Question 7. Which of the following statements concerning breast cancer staging is correct? A. Stage 1 tumors have no metastases to either lymph nodes or distant sites. B. Stage 3 tumors include some with distant metastases. C. Inflammatory carcinoma is considered T4 disease. Or D. N4 disease includes metastases to highest contralateral axillary nodes.
C is the correct statement. Under AJCC rules, inflammatory breast cancer, which you'll recognize by those very specific orange peel-like Poe-Dameron skin changes, is automatically, right off the bat, designated as T4D disease. Just to clarify the others, Stage 1 can actually include micrometastases, Stage 3 strictly excludes distant metastases, and there's actually no N4 tier at all. Your clinical exam pearl here is that a Poe-Dameron presentation immediately dictates a minimum T4D staging, totally regardless of the actual tumor size.
Question 8. Which of the following statements about the management of ductal carcinoma in situ, or DCIS, is true? A. DCIS treated by mastectomy has a local recurrence rate of less than 2%. B. Extensive DCIS should be treated with tamoxifen followed by lumpectomy. C. Specimen mammography is only useful for patients with small amounts of DCIS. Or D. Postoperative tamoxifen is useful in DCIS patients whose tumors are estrogen receptor negative.
The true statement is A. Mastectomy is still the most definitive option we have for extensive DCIS, meaning disease that's larger than 4 centimeters or spans multiple quadrants. The outcomes are incredibly favorable, with both recurrence and mortality rates sitting below 2%. Also, specimen mammography isn't optional, it's absolutely mandatory. For all non-palpable calcified resections, just to guarantee you've got clear margins. And tamoxifen? It only works if the DCIS is actually estrogen receptor positive. So the big exam pearl, mastectomy is the definitive treatment for extensive DCIS.
Question 9. In which of these clinical scenarios is a sentinel lymph node, or SLN dissection, acceptable and recommended? A. Inflammatory carcinoma of the breast. B. Prior major axillary disrupting surgery. C. Biopsy-proven palpable distant metastases. Or D. Primary breast lower inner quadrant invasive carcinoma.
If you said D, you're right on the money. SLN biopsy is the absolute gold standard for evaluating regional nodes in clinically node-negative breast cancers, and it doesn't matter at all which anatomical quadrant the primary tumor is sitting in. However, it's explicitly contraindicated if you're dealing with inflammatory breast cancer, biopsy-proven axillary macrometastases, or if the patient had prior axillary surgery that messed with the native lymph channels. Your exam pearl to lock away is that tumor location or quadrant does not contraindicate an SLN biopsy.
Question 10. Which of the following is true concerning breast cancer presenting during pregnancy? A. Metastases to axillary lymph nodes occur in approximately 75% of these patients. B. Approximately 50% of breast nodules developing during pregnancy are malignant. C. Mammography is especially useful in localizing small lesions. Or D. There is a high risk of chemotherapy teratogenicity if used during the second but not the third trimester.
The correct, albeit tough, reality is A. This is a massive clinical challenge because normal gestational engorgement of the breast tissue can hide things. Delayed detection is super common. This means breast cancer during pregnancy often presents at a much more advanced stage. So you see axillary lymph node metastases in up to 75% of these women. Luckily, fewer than 25% of new nodules that pop up during pregnancy are actually malignant. For your exam pearl, standard chemotherapy regimens are totally contraindicated in the first trimester, but they're considered safe during the second and third trimesters.
Question 11. Which statement about breast anatomy and vascular supply is true? A. The lateral border of the breast is the posterior axillary line. B. The largest breast quadrant is the inner lower quadrant. C. Vascular supply is via posterior intercostal arteries, the internal mammary arteries, and the axillary artery. Or D. Cooper ligaments are only found in the upper quadrants of the breast.
The true statement is C. The breast gets its main arterial blood supply from a very specific triad: perforating branches of the internal mammary artery, lateral branches of the posterior intercostal arteries, and branches coming off the axillary artery. Looking at the boundaries, it actually extends transversely to the anterior, not posterior, axillary line. Plus, the upper outer quadrant is the one that packs the largest volume of functional tissue. Your anatomy exam pearl. Memorize that exact triad of arterial supply to the breast.
Question 12.
Which of the following pairs of hormones and their specific physiological effects on the breast is correct? A. Estrogen is responsible for lobule development. B. Progesterone initiates ductal development. C. Prolactin is responsible for milk letdown. Or D. Oxytocin initiates contraction of myoepithelium.
D is the correct pair. Oxytocin, which gets released by cues like suckling, drives the immediate contraction of those surrounding myoepithelial cells to literally squeeze and expel the milk. That's your letdown reflex. On the other hand, estrogen is mostly responsible for ductal development, progesterone handles lobular maturation, and prolactin is the actual trigger for milk production or lactogenesis. The final exam pro to always keep straight: distinguish prolactin, which makes the milk, from oxytocin, which ejects the milk. So what does this all mean for you clinically? Just remember how these baseline physiological pathways drive the exact pathologies we just ran through.